Good evening, everybody. Welcome to MS Neuro TV. My name is Jennifer Falk. I'm the Director of Development over at MS News. And tonight I'm here with our Productions Manager, Bill Shanley. And our special guest tonight is Connie Easterling. Just to give you a little background, MS News is a nonprofit organization dedicated to providing education and information to the multiple sclerosis community. And before we go any further, we definitely would like to thank our supporters for MS Neuro TV, which tonight is Novartis and Bristol-Myers Squibb. We are very grateful for their support in making educational programs like tonight possible. So thank you for that. And you know, just to let you guys know, we have now over 1,400 people who are registered and engaged in MS Neuro TV, and that's just very powerful. It just really says a lot about all of you who are just staying empowered and staying engaged, even during this time, you know, looking to make these connections and looking to keep learning. And we're just so glad that you're on the line with us, that you continue to learn on this journey with MS, and that you just continue to come back and either watch us live tonight or watch the recording on YouTube. So that's just an awesome thing, and we're really glad to be able to do this together. So moving forward, tonight's topic, one other note I want to make, and I really have to apologize for this. We noticed today that the topic on the email was still last month's topic, unfortunately. Last month we covered neuroplasticity and physical therapy with Dr. Gretchen Hawley. If you missed that and you were thinking that that's tonight's topic, please write to me, jennifer@msvn.org, and I will send you the recording of last month's episode, which was the neuroplasticity and physical therapy, and it was excellent. I'd be happy to send you that one. So tonight's topic, and I hope that you will all still want to stay on for this, it's a great one, we have a very great guest speaking about it, is women's health in multiple sclerosis. And we're going to talk about relationships, we're going to talk about mental health, we're going to talk about intimacy, family planning, menopause, and I've got a lot of great questions coming in from Instagram, and people have written me directly in advance with all of your questions, and we love that. So just so that you guys know. And just to give you a little bit of background about our special guest presenter, Connie Easterling. Connie Easterling is an adult registered nurse practitioner and clinical coordinator for the MS Care Center of Neurological Services of Orlando. She is a graduate of the University of Florida with a Master in Science and Nursing, her MSN, and her practice has been limited exclusively to multiple sclerosis since 1998. Connie is an advocate for individuals living with MS, and she serves on the Clinical Advisory Committee for the Mid-Florida chapter of the National MS Society. Connie promotes MS education by speaking frequently to the community, students, and professional groups throughout the United States. And we're really happy to have her with us tonight. So we're going to get started. Just so you know, we're going to play a great video that was an interview between Connie and Stuart Schlossman, who they have pre-recorded this interview. And so as you're listening to them speak and you can hear and kind of process what they're talking about, you can go ahead and start typing in questions. You can find the question board up on the top left corner. You should see a little red arrow, and that should open up your question panel. And you can just, anything related to tonight's topic, just shoot over any thoughts you have, anything you want me to share with Connie. And once the video is over, we'll just start with Q&A with Connie. And just please know that those of you who are calling in over the phone and you don't have video access, there's going to be a block of time where this pre-recorded video, you won't be able to hear that. Unfortunately, the GoToWebinar platform doesn't allow you to hear pre-recorded videos. But if you stay on during the interview, you will be connected back with us for the live Q&A, and that's always a great conversation. So I hope you guys can stay on for that as well. And Yeah, I think we'll get started with the video. If you could play that, sounds great, Bill.
Good evening, everybody. I'm Stuart Schlossman from MS Views and News, and we're here again with Connie Easterling, a very well-known nurse practitioner from the Orlando area. There are so many patients up there that just love seeing her as often as they can to get in there, and they feel better when they leave. So, Connie, we want to speak today or tonight about women in MS, a discussion on the family planning, pregnancy, relationships, intimacy, menopause, and more, all in a very short amount of time, right? All right, so to start off with, as multiple sclerosis often affects women during the prime of their lives, challenges are presented in many different aspects of relationships to family planning, reproductive health, careers and family responsibilities. Women manage significant roles in today's busy world. In your practice and experience, what have you seen that has helped women successfully manage living with multiple sclerosis?
Fortunately, in women, their average age is about 32, but it can occur anytime between 15 and 50. They're usually diagnosed in their productive years. So we spend a lot of time in educating the patient thoroughly about the disease. We teach them about treatments. We teach them about all the aspects of controlling MS, and then we want them to live a healthy life. I used to work for a doctor, Victor Robert. He's retired now, and he used to say 50% of taking care of MS is a wellness perspective. That was 20 years ago, and now we know that's true. So we want them to eat right. We want them to be active, exercise if they can. We want them to be social, join a support group, or if they don't want to, they can involve their church friends or whatever their social group is. We want them to be socially active. We want them to live as a whole person and not hide behind multiple sclerosis. So, and we want them to reach their goals. So if they want to go to college, and we help them with that. If they want to have a baby, we're going to help them with that too. So
You help them make a baby?
not really,
I
but
didn't
we
think so.
we encourage them to make a baby the safe
There
way.
you go.
Okay.
Great. So tell me about exercise. I mean, how do you get women to understand, even men that come to your practice, how do you get them to understand that just a little bit of exercise will help them out?
We tell them that even if you walk for 15 minutes, I have patients that still work, but they can't be out in the heat, and they can't afford to go to a gym. So they go to the mall and they walk around the mall for 15 minutes. That's all they need to do, and only maybe 3 times a week. So we start minimal. We don't make them go get on a treadmill for 2 hours, but we start minimal and we build up over time. And most of them recognize that everything they do can be some form of exercise, all movement. We want them to move.
True. What is the ratio of men with MS versus women with MS?
Well, it depends on where in the globe you go. So in the United States, it's about 3+ to 1. Most people say 3 to 1, but it's climbing. And so one of these days, I think it's going to be 4 to 1. In Brazil, it's 1 man to every 9 women.
Wow.
And in Australia, it's 1 man to every 11 women. So it's different, but in the United States, there's 1 in 1,000 who will be diagnosed with MS, and it's certainly more common in women than in men.
So you gave those numbers about Brazil and Australia. What about like the UK, Norway?
Well, the UK has a tremendous amount of MS. I don't know the ratio there, but I know that in Canada, it's very prevalent in women. And they have 1 patient in every 400 in Canada has multiple sclerosis. In Brazil, it's 1 in 5,000. So it's different everywhere. But the further away from the equator, the cold countries, northern European countries, you're going to have a lot more MS, and the prevalence is towards women.
Thank you. Can you tell us how women are affected psychologically and emotionally?
Yes. So women are very emotional beings, as you probably know, and they are concerned about how their appearance is. They're concerned about how they look. They want to have a love life, so to speak. They want to have a relationship, and they're very afraid of having a visual level of disability. And so if they do accrue disability over time, they can become, there can be issues with body image. Women have they're so concerned about their body image, and so that can lead to depression if they have some level of visible disability. So we have to work with our women on changing that. Don't look at magazines. Don't watch some of these TV shows where everybody looks perfect like a Barbie doll. You need to find within yourself your real being, and don't pay attention to your physical deficits. Wear clothes that are comfortable to you to make you feel attractive, and so forth. So we work on all this self-esteem, and most of the time we have to refer to counseling. That's very important. Counseling is very important.
Great, thank you.
You're welcome.
When it concerns parenting and relationships, what do you speak about with women that come to see you?
Well, I tell women that, especially when they're first diagnosed, they've got to go home and talk to their significant other, their spouse, about the diagnosis. If they don't come with us to the first visit, they may have teenage children at home. You have to be honest, and even if they're elementary school children, they're going to know something's wrong because of the way you present and your partner presents and the emotional situation in the home. Be honest, according to their age level and what they can understand. Very simply, tell them that you have a disease that may change you over time. Many times the children, even the teenagers, want to get involved in that. And you've seen that even in your own program. They volunteer, they go to the walks, and they're happy to do so. But being open communication with your spouse and your children is very important. And everybody's going to go through a time of adjustment, and it may not be pretty. But in the end, if you're honest and open, the outcome will be better.
Thank you. What can you tell us about the common challenges of stress, depression, self-esteem?
So there are common, and it takes such a toll. So stress, as you know, is the enemy of MS. You should know that. And so we teach that very up front. So I have women who work 60 hours a week at a job. I have men that work more than that. They're executives. Have a very important job, and that wears a toll on them over time. And the stress of that will be detrimental. Many people realize that over time, and they have to step back. I have a gentleman that didn't want to file for disability, and we encouraged him to. He had cognitive changes that were quite obvious, and he didn't want to file. He had a really nice job, but he decided to take a lesser job with lower pay, so that he could keep working.
Exactly.
Like you and I, we love working,
exactly.
Right? So we do have to work with them on that. We do encourage them to get counseling and so forth, but we have to work with them on the stress. And then sometimes with stress and then comes anxiety, and they don't know how to cope. And then with anxiety comes depression. We can treat depression. We can give them a pill to make them feel better. However, there are side effects to that, and plus, counseling and medication works better than either one apart. So we encourage both of those.
So now let's talk about pregnancy.
Okay, I love that topic.
Okay, pregnancy, but let's talk about it also with regard to the medications. I mean, how do you, when a patient comes to you and says, hey, I want to have children, do you have to maybe change their medication?
Certainly do, because none of the treatments are approved for pregnancy, although we do have several medications that we've had many years, 20 years or more, and we know that through history that these medications do not cause any harm to the fetus, to the baby. So one is Copaxone. So if a patient has, or a person has aggressive disease and they get pregnant, which we don't want that to happen, then we'll put them on Copaxone, or we'll put them on the interferons. The interferons have proven over time to be safe. We do not want them to do that. We would prefer that they stay on contraception and they discontinue the disease-modifying therapy first and then plan that pregnancy. So, for instance, if a patient's had a bad year, multiple relapses and progression, We want them to stay on treatment until they have a really good year, because the year after pregnancy mimics the year before they got pregnant. And so we want to provide them with the best year, because if that happens, if they have really aggressive disease, then after the baby comes, they may have aggressive disease, and then there's an issue of child care. So we work with our patients, and we begin that with the first treatment with our young women. What are your plans? And
Sure.
let's plan it together.
So you mentioned the word Copaxone, but for those that are on generic formulas of it these days, same thing applies?
Yeah, the glutathione acetate, the generic form, does apply.
Right, great.
But we don't want them on any of the other medications, because it can cause problems with the baby. But pregnancy alone does not cause any harm to the fetus. It doesn't cause stillborns. It doesn't cause spontaneous abortions. MS does not lead to any damage to the baby. And so it's safe to have a baby when you have MS.
Right. But for those that are using medications, can they do breastfeeding?
Yes, there are some. They're not approved. None of them are approved for breastfeeding. So we discourage that because we have to. But there are some drugs that don't, that are thought to not go through the breast milk. Even steroids, we used to say you have to pump, if you're breastfeeding, you have to pump and dump for several days. But now we've learned that steroids, if you wait 4 hours after your last infusion, the baby's exposure to steroids is very minimal, so we can treat them. But the best outcome would be that you don't take a disease-modifying therapy if you're going to breastfeed. That would be our advice.
Now, I know this is a great subject coming up for you because I've heard you talk about it, but women that have problems with their sexual performance,
yes,
okay, and their challenges that they have with that, what do you tell to women?
Well, preferably, I do talk to women first, but I need to talk to that significant other. It's very important that they understand what's happening. But I tell women there are modifying things that we can do. We can modify, if it happens to be positional, if your legs get spastic during sex, then let's work on that antispasmodic drug. Some women have problems with their bladder during sexual act. So timing is very important. It's very important to space drinking water and that sort of thing. So there are interventions that we can do so that they can have a successful sexual act. But sometimes it's the partner that has a problem with that. They have a little hang up. So if we can talk to them and work with them, we try to do that. But we want our women, men tend to see intimacy as sex. That's true. But women see intimacy as so much more. They're more emotional. They want to have intellectual intimacy, and that's talking to each other. They want to have social intimacy. They want to know what you've done through the day, what you've done when you aren't together. They want to...
Men don't have time for that.
No, but it's all part of intimacy. Intimacy is being close with someone that you care deeply about, and it's being very close. So we encourage that, and the partners have to understand that.
Yeah, so now, though, going forward with that, because again, I've heard you talk about this, when there's desensitizing to the body.
Yes.
Okay. Yes. The audience, they're going to want to hear about this as well. I mean, what do you recommend for where there's just lack of feeling?
Yes. So the youngest person that I ever had with MS who had numbness from the waist down was a 19-year-old female. And it was devastating to her because she had just started a relationship when she got diagnosed. But when there is a lack of sensation around the external genitalia, women can use estrogen creams, and so you just and of course we send them to their gynecologist, of course, to get examined, but they can rub the estrogen cream around the clitoris, and over time the clitoris itself will become more sensitive, and we've had great success with that. So that is a problem, and there are other agents we use like gabapentin and that can minimize that sensation of numbness and tingling. So whatever we have to do is what we do.
Okay, can you share with us some suggestions that you may share with patients or couples who present the challenges with the transitions during their intimacy?
Yes, and so as you know, over time, the spouse becomes the caregiver. And so it's very hard for we have to make sure that our patients understand that being a sexual partner and emptying the bedpan is very difficult. And so there's a lot of adaptation that has to happen. And we do have sex counselors. I looked it up in Orlando one time. We have 7 sexual counselors in Orlando. And a lot of time we need to involve those people to help them understand and help the woman understand. And plus, you know who can help with that? Occupational therapists very often teach how to have sex when you have a physical deficit. So we involve them too.
How do you recommend having conversations around the changes and transitions in intimacy with the healthcare provider?
For the patient to talk to us? Well, when we see patients, when I see a female, I don't know what other people do, but when I see a female patient, even at the very first visit, I ask them questions. Do you have any sexual dysfunction? And then I give them examples of that. Whether the partner is there or not, you have to get it out in the open. And I present it like it's normal so that they won't be uncomfortable. When I see a woman who, in the presence of her husband, asks, "Can I talk to you privately?" I know exactly what she's going to do, and I do meet with her privately, but I encourage her, let's go back and encourage your talk with your partner and you together, because we won't be able to fix things and work on things if we don't. So getting it out in the open. I ask the questions. I usually get a very shocked face, but I think if you get it out, then they won't be afraid to talk to me later about it. We encourage that.
Clearly, you are a woman.
Yes.
And your female patients can come to you and speak to you more freely. But what do you recommend to women with MS who see a male neurologist and there is no nurse practitioner in their office?
Well, in my office, we have 3 or 4 doctors at any given time, and they run them down the office to see me. So if you're uncomfortable talking to your male healthcare provider, then ask, you can see the nurse practitioner. There's always going to be practitioners or PAs in the office that are female. However, patients need to learn to talk to their male healthcare providers, because I know there's a lot of them that don't have NPs or whatever in their office. You just have to be open and honest and see how comfortable they are with it. If they're uncomfortable, then you ask them, who can I talk to about it? Okay. But you have to initiate that, and don't be afraid.
Great.
And they are afraid, but don't be afraid.
That's right. Thank you very much for this very intellectual conversation. I'm glad that you were with us tonight. And for everybody that's watching, thank you for watching, and I hope you have questions for Connie.
Okay, hi everyone, we're back, and I hope that you enjoyed that interview and it sparked some ideas and thoughts that you might want to share. Connie, I would like to welcome you live with us. Welcome to MS Neuro TV, Connie.
Thank you, Jennifer.
Great to have you here with us tonight.
I'm glad to be here. Thank you.
Absolutely. So, we did that interview with Stuart some time ago, but it's just like it happened yesterday, and the questions and responses are great. They're just great.
Thank you.
Yeah. So I have a lot of questions for you, and I'm going to start kind of putting it into topics. And there's a lot of questions around menopause. And so I think we'll start with somebody is asking, can the beginning of menopause cause an MS relapse?
Yes, very interesting. Menopause can be a very challenging time for a woman with multiple sclerosis, because during menopause the hormones are sort of out of balance in relationship to how they are when you're younger. But menopause in itself raises the core body temperature. So if you were even the slightest bit sensitive to heat, you're going to react. It's just like when a woman's on their menses, when they're in the menstrual cycle or their period, if you will, their core body temperature goes up, and during that week, they seem to have more symptoms related to their MS. So menopause doesn't necessarily cause relapses, but it does cause an embellishment or of the old symptoms, so they seem to be worse. Sometimes we use just an aspirin a day. Sometimes we use a prednisone a day if the symptoms are unbearable. We do work with our gynecologist for hormone therapy if that's needed. A lot of gynecologists are not using hormone therapy anymore because of breast cancer and phlebitis and that sort of things. But when a woman has a lot of significant symptoms during that period, there are some interventions that we do. But menopause in itself is not related to relapse.
That's so interesting. And you answered in your answer, I have 3 questions very similar that are saying, is it common for my symptoms to get worse during my menstrual cycle? And
yes,
so
very common. And so during that week of their menses, we tend to do interventions that are somewhat different. And it's very difficult for women to manage the symptoms during that time. But, and we do work with our gynecologists. Sometimes they have interventions that they would like the patients to do, and there may be interventions that we would recommend as well, but it's very common.
that's so interesting. So definitely a conversation that can be approached on both the neurology side and with the OBGYN.
Right.
Okay. Okay, great. And someone's asking a more general question about myelin, and if in women, if there's a more possibility that it can repair versus men.
You know, I'm not sure that there is related to gender or not. And they may be thinking more of relapsing and remitting versus primary progressive, because more women, 85% of women have relapsing and remitting MS. And then there is a fair amount of men who have primary progressive. So if you're relapsing remitting, the myelin repair may come more readily. You have to remember that in primary progressive MS, the damage may start in the gray matter versus the white matter. And so regeneration of the myelin may be somewhat more difficult. And when you think of it that way, myelin repair may be, if it does come, it may come more readily when there's inflammation. So in relapsing and remitting MS, those lesions are inflammatory. And so the oligodendrocytes, which are a special cell within the central nervous system, they're always trying to remyelinate those areas. So as the inflammation goes away, the oligodendrocytes try to remyelinate. And then, of course, there are there's a lot of research in remyelination. And primary progressive is more of a degenerative disease, whereas there's more axonal damage, and that when that happens, it cannot be repaired. Does that make sense, Jennifer? So it's hard to think of it as women versus men. Yeah. It's more in the type of MS, yeah.
Okay. And you mentioned before core temperature and heat sensitivity. So somebody's asking if you could explain how heat affects people that are living with MS.
So it's a very difficult thing in Florida to live with the heat. In fact, I have several patients I've seen just over the last couple of weeks. We're doing telemedicine, so I do still see them over the computer, but they feel like they're in an absolute relapse. The heat zaps their energy. It makes it difficult for them to move. It may make bowel and bladder symptoms worse. It may cause headache. and it may cause areas of numbness and tingling that were and symptoms that were old in their past seem to come forward, and so they feel like they're having a relapse. And usually it can be very difficult to deal with. So just like the MS Society, they have a wonderful page on heat sensitivity and what to do about it. We encourage our patients to stay in air-conditioned environments when they're in their car. Make sure they cover their windows from the sun. They drink cold water while they're traveling. They can wear cooling equipment. In fact, the MSAA will provide free cooling equipment, such as a scarf, a cap, wrist bracelets, and also a cooling vest. Although in Florida, the cooling vests tend to melt pretty quickly. So, but there's all kinds of things you can do to keep cool in Florida. But the best thing to do is to stay in the air conditioning, because I know some patients just walking to the mailbox will zap them totally.
Oh wow, yeah, that's tough. Really tough. Someone's writing to us, Connie, that they're looking forward to educating their husband on all of these answers. And I just want everyone to know that this is being recorded. So if you do want to share this with your husband or your partner or people in your family, just visit our YouTube learning channel. It will post in about a week. Or if you need it and you can't find it, you can just write to me and I'll send it directly to you. So our next question, someone is writing about their experience. It's personal, but I always feel like someone's experience could help somebody else that probably has something a little similar. So this person is writing that she said that she has fatigue all day, her menstrual cycle is erratic, and she has no desire for intimacy, and she's asking what she can do to improve her desire for intimacy.
Oh, bless her heart. So first of all, it's increasing your libido can be done through medication. We have medications now that increase your libido, but intimacy is a very personal thing, and intimacy can mean many things. It can be touching. It doesn't have to be sex, although sex is part of intimacy. It's just how you feel about yourself, your outlook about things. But relationships are very important, and how much you share with your spouse or your significant other is very important. But to feel better about yourself and for women, it's a real thing. MS can change their outlook about themselves. It can change how they relate to other people. But it's very important that you're open and honest in your communication. And if you find that your husband is not interested in sex, you can leave tips around the house. You can make suggestions. Sometimes I have patients leave movies out just to make sure that you're leaving those tips that you're interested in being intimate. But if the libido is low, there is a medication called trazodone. It's an antidepressant, but what it does is it increases the libido. I've used it quite a bit, and even low doses in my patients, especially my female patients, they have had great success with that. So that's one thing I would suggest. Counseling is another. A woman's outlook on herself can drive her libido. It can drive her relationships with others. So if that's an issue, I think that they should seek counseling, and there are sex counselors as well. And you can even suggest that you and your significant other go together.
That's such great advice. Thank you, Connie. Somebody's asking about gabapentin and if this helps with hot flashes for menopause.
Yes. Gabapentin is a great drug. You know, it's actually an anti-seizure medication, but it's a mild anti-seizure medication that when it came out in the 90s, we realized that it worked better for sensory symptoms and multiple sclerosis. So we use gabapentin for a lot of things. People who have oversweating, gabapentin can suppress that. If they have numbness and tingling, gabapentin can suppress that. So gabapentin can can treat most symptoms. It's even good for spasticity when our baclofen or our tizanidine doesn't work. So it would be a good drug to try. We tend to go low dose, 100 milligrams to start with, and then we increase the dose over a period of time, and then we stop the dose when it's effective, when it's been effective. So that would have to be determined by a physician, and so the individual should talk to their neurologist or their primary care about it.
Yes.
Okay.
And somebody is asking if MS can stop or interfere with your monthly menstruation.
MS specifically has no effect on the physical, the woman's reproductive cycle. However, I think that when a woman is diagnosed with MS or a young woman is diagnosed with MS, the stress of having MS, the stress itself can impact their hormones and impact their menstrual cycle. If that makes sense.
Okay. And during your interview with Stuart, you talked about mental health. You talked about depression. How prevalent is depression for people living with MS, maybe specifically women living with MS?
So depression is quite prevalent. In fact, we know that about 70% of individuals with MS will have a major depressive event over their lifetime. We know that depression can get worse in the presence of fatigue. Sometimes we don't know whether it's fatigue or depression, but fatigue is the number one symptom of depression. And so it can happen in both men and women. Sometimes I think it's easier to treat in women because they're more apt to be willing to take an antidepressant. Doesn't mean you have to be on an antidepressant for a long period of time, but we recommend to start with an antidepressant and also to seek counseling because both of those together work better than either one of those alone. So I think the important thing is to recognize it. In our practice, we look for depression at every visit. We talk about depression. We talk about suicidal ideation. A number of people with MS during their lifetime will think about hurting themselves. And so we want to catch those symptoms early, and we encourage our patients to call us so that we can work with them. However, don't keep it to yourself. Talk to another person about it. Talk to your healthcare provider about it and seek help before it gets worse. Don't ignore it.
Okay, excellent. Thank you. So depression, feelings of anxiety, these are things that can be addressed during a neurology.
Yes, right. And anxiety can come with or without depression. Anxiety is very common, especially early in multiple sclerosis. People will go through that anxiety of having a overwhelming disease, and so they'll become very anxious about it. We do have medications that we give for anxiety that are only for the short term. We call them anti-anxiolytics, like alprazolam. That can be used for up to 6 weeks. But to treat anxiety, we usually do use some antidepressants that will suppress that anxiety. But it's very important to discuss that with your healthcare provider as soon as it occurs.
Okay, thank you, Connie. And you mentioned counseling. Any specific type of counseling? Any specific type of counselor? Mental health counselor, psychologist?
Right. There are several. Right. There's several types of counselors. So There are psychologists. We happen to have one in our office who does neuropsychological testing, but he doesn't do counseling. There are other neuropsychologists that do both testing and counseling. There are LCSWs. They're licensed clinical social workers, and they are great at doing counseling. And sometimes it's hard to find counselors like that out in the community. And so you have to, I know I can't think of their names right now, but I can see their faces. So you have to look them up, call the MS Society, call the MS Foundation, and they will give you specific names of people that do counseling. Many counselors work in psychiatrist's office, so your physician may refer you to a psychiatrist. Psychiatrists used to do a lot of counseling, but they usually refer to a psychologist to do the counseling. But that you can be a licensed counselor, LCSW, or a psychologist to do counseling. So, but it's like a marriage. So if you have one counselor that you don't like, then you need to try somebody else. So it has to be someone that you have confidence in, that you can open up to them, because you really need to be honest and open. And it may include a member of your family that goes with you, but you have to find someone that you really feel that you can open up to.
Absolutely, absolutely. And I know, Connie, you're practicing telehealth in your practice, and I know that there's many mental health professionals that are also practicing telehealth. So, with everything that is going on, it's still an option to reach out to a counselor. And I know that there's many online programs that will allow you to just have that initial meeting, see if it's a good match, if it's a good, connection between the two of you, and then you can take it from there. And they bill through insurance that way also. So definitely to reach out to the society, like Connie is saying, to the MS Foundation, and see if they can refer you as well to some type of counseling, if that's something that you think could help.
Right.
That's great. And I'm just
the important thing is to just open up about it. Be honest and open up about it. Too many people don't talk about it.
Yeah.
So
it's kind of the missing piece, or you just suffer silently, and there can be so much more.
Right.
Make that connection. So, and Connie, you recently gave a talk about wellness and aspects of staying active and things that can also help with mental health and just kind of getting through, especially today. Can you share with our audience some of your top recommendations of what you really talk about with the women that you work with in your practice? Yeah.
Right. So, I always talk about wellness being 6 dimensions. Environmental health, physical health, social health, emotional health, spiritual health, and intellectual health. And all of these you have to attend to all of those to experience true wellness. There are some things that you can do that incorporate wellness and health. One is sleep. If you're not sleeping, I find that most MS patients never sleep. So you should be sleeping really sound sleep, 7 hours every night. If you don't, it can cause worsening of depression and some of your MS symptoms, as well as cognition. And then exercise. Exercise is one of the best things you can do for wellness. It increases brain volume. It gives you a sense of well-being. It decreases depression, and it improves mental and physical health. Eating. Nutrition is very important. I find sometimes that individuals who are having difficulty coping, they don't eat, they don't drink, but you should drink lots of water. 13 glasses a day has gone up since it used to be 8 glasses. 13 glasses of liquid a day. And eat a good, healthy, nutritious diet. And I could go over many diet types, but if you follow the food pyramid, or the Mediterranean diet. Those are good sources to start with. And one of the biggest things I tell my patients is take vitamin D. You know, I think that I meet so many people with MS that don't take vitamin D, but vitamin D actually affects your immune system. It suppresses the pro-inflammatory cells that lead to demyelination, and it has an inverse relationship with worsening disability. So, and even with the COVID virus, we've learned that people who take high doses of vitamin D for long periods of time may be resistant to that virus. That's part of the early research they found out. So the optimal level for vitamin D in an individual with MS is 70. So most people with MS hover around 30 or below, and that's abnormal. So make sure you find out your vitamin D level, and you can either take it over the counter or you can get your physician to write a prescription for vitamin D. Either way, so make those healthy lifestyle choices. No smoking. Smoking can make your MS worse. It's very important that you don't smoke. It can worsen your immune system. It can worsen your MS, and you can have more physical symptoms if you smoke. So I think that hits about everything. One thing I just want to say about healthy living and wellness is mindfulness. So mindfulness means taking time out of your day to contemplate yourself. Be aware of your thoughts, your feelings, your body sensations in a quiet environment. And just think about gentle nurturing of yourself, and accept yourself. Pay attention to your thoughts and feelings. Don't judge yourself, but believe in yourself and believe that you can have a positive outlook with your MS, and mindfulness is a great way to start. Some of the benefits of mindfulness can decrease your blood pressure, can improve your immunity, your immune response, and make you overall feel better, and it can decrease depression and anxiety. So I think that's it, Jennifer. I think I just gave a whole program in 5 minutes, but there's a lot of things we can do to be well.
Those are such wonderful recommendations, and it sounds like a lot, but it takes a lot to really incorporate self-care and take care of ourselves.
Yes, it does. And right, and getting back to relationships, opening up to others, being open and talking about yourself and your disease. You don't have to tell them you have MS, but relationships are a very important part of well-being.
That is a big question. I actually did have one more question for you, but you were bringing it to such a nice wrap up there. But I have a question on dating, and I know this question has come up in the past, and women ask, when do I disclose that I'm living with MS in my dating process? Like, when is the right time to let somebody know?
Right, and you'll know when, but some people disclose too much too early, and when you do that, you don't know how the other person's going to react. So it depends on who the person is. If they're a family member, a spouse, it may be easier to disclose, but you don't have to disclose to anyone. If you're new in a relationship, you may want to ease into that topic, but if you feel comfortable with that person and you feel like you want to share, then that is the time to share. You will know, but we never know how other people are going to react, so be prepared for their reactions, and be prepared for your response to that. But I would ease into it, really, if there's someone that you're just dating. It's not like a husband who you would want to tell.
Oh, well, thank you so much, Connie. You are so wonderful, and this has been so authentic, and I think it's really helped a lot of people. We're so grateful to have you on with us.
Thank you very much, Jennifer.
Absolutely. And I'm just going to wrap up and give some information to everyone.
Okay.
Yeah, so next month, and this will really tie into everything that Connie was just leading us into. Next month's topic is going to be mental health. and challenges of depression and anxiety in MS. And we're going to have Dr. Rick Harris, who is also a very big mindfulness practitioner. He is a psychologist, and he'll be joining us next month. So I definitely encourage all of you to join us again, and that's going to be on September 1st. If you are on tonight with us, that means you're registered already. So you may see promotional emails or something about it that say register, but you don't have to register again, because if you're registered for this one, you're registered for the whole series, just so you know. And we'll be happy to have you on next month on September 1st with Dr. Rick Harris. And for all of you who are joining us, just know also that tonight's program, again, will be on our YouTube learning channel. If you have trouble finding it within the next week, we're going to post it. If you can't find it in about a week, you can always write to me at jennifer@msvn.org, and I'll be happy to send it to you. And all of our webinars and everything else can be found there on the Learning channel. If you subscribe, it'll also alert you when we post a new program. We do a lot of online programs now, and I encourage you to just keep learning, keep connecting with us. This time we couldn't see each other, but next time I think we'll try to put a camera on with us, Connie, so we can all see everybody. I think that would be nice. And so we really encourage you to just stay connected. Visit us at www.msviewsandnews.org. And you guys know we're on Facebook. I see you on Instagram. I think you're all awesome. And again, we want to thank our supporters for tonight's program, Novartis and Bristol-Myers Squibb. Thank you so much. And thank you for joining us, everyone. And also, please, you're going to get a survey. And I really, if you could just fill that survey out, tell us how we're doing, give us some ideas on any feedback, any questions, any future topics that you'd like to learn about. We read them, we see you, we want to learn more about what you want to learn more about, and we really value your opinion. So you'll get that in an email, and I'd love to hear your feedback. And thanks, everyone, and we'll see you next month. Have a good night.